Hello, and welcome back to the Lube Tube. This is Jeanette and my co-host, Brittany.
Hi, guys. I actually just want to start by apologizing. My voice is half there. I was on vocal rest on Sunday.
Vocal rest.
And it was the hardest thing. Do you know how hard it? Oh, gosh.
Oh, here we go.
As a talkative person, it's very difficult to be on vocal rest.
So she sent me a voice text and she sounded really bad. So I immediately wrote back and I was like, hey, you just need a vocal rest. And I'm not sure how that went.
Clearly
she talks a lot.
Worked.
No.
Clearly. All right, let's get into it.
All right. So welcome to episode 5. This episode is one that I get a lot of questions about during the day from some of my younger girls and even my older women. But this episode is called Cyst Happens and How to Deal with It. So this is guidelines to Polycystic Ovarian Syndrome, or PCOS for short. This is a buzzword. I'm sure you've seen it on multiple social media sites where people are talking about PCOS. I know it's big on TikTok right now because I'm a really big TikToker. I don't know if you knew that. But yeah, PCOS is something that patients are coming to me and they're already somewhat educated on. And they're asking me questions on how I basically can diagnose them if they have it. And we talk about all these things. And so I kind of wanted to do an episode about this and kind of give a little bit more information than maybe the media is giving and kind of get a little bit more deep into just kind of what it is and how we go about diagnosing and treating it. So what is PCOS? PCOS stands for Polycystic Ovarian Syndrome, okay? PCOS is, I saw somewhere that somebody put where your ovaries are overreacting. I thought that was
that's cute.
Very cutesy.
That's very cutesy.
It's basically a problem with our hormones that happens during the reproductive years. So during the years that we are able to become pregnant, okay? So this is prior to menopause, prior to perimenopause, but during the time where we're supposed to be ovulating and having a period at least once a month, okay? What's happening is the ovaries are creating multiple small sacs where they are supposed to be creating follicles, and these follicles are then failing to ovulate. So what that means is our ovaries every month are basically trying to create a follicle that will be released in order to become fertilized. And what's happening with PCOS is there's multiple cystic lesions instead of these follicles being released. And so these fluid-filled cysts create problems moving forward with lots of things, okay?
So you could almost think of these as immature eggs that never reached a point of being released or fertilized, whatever it may be.
Exactly. So the problem with that is when these follicles fail to release regularly, it can lead to a whole slew of symptoms. Okay. And we're going to go through that and kind of talk about what each of those are and hopefully give you some insight on kind of how to basically describe this to your provider and kind of talk to them about maybe you're having some of these symptoms and maybe you have this and you didn't even know.
Right. Because PCOS is actually very prevalent.
Mm-hmm.
One of the big reasons PCOS is starting to be talked about more is because fertility has become obviously a bigger issue, or is just being talked about. Infertility, I should say. Mm-hmm. And PCOS certainly can affect fertility.
Yeah. This PCOS, or polycystic ovarian syndrome, it affects millions of women worldwide. And I think that more women, as they become more comfortable talking about their health, they're also realizing that they are also affected by this and they're more willing to talk about it, right? And they want answers. And I love that for them. And so that's why they're coming to me already educated on this. And I'm glad that I'm able to provide that place for them so then we can figure this out and get basically some answers and some solutions.
Right. And it's just a statistic, because statistics are fun. Mm-hmm. It affects 1 in 10 women globally.
Wow, 10%.
Wild.
That is a lot. Like if you were to take 10 of your girlfriends right now, at least one of them would have PCOS or symptoms of PCOS, and maybe they don't even know that they have it. You know, I have some women that had no clue that they had PCOS, and it was found on ultrasound, actually. So it is common in women aged 15 to 44. So like what we talked about, you know, it happens during that menstrual years, right? The years where we're having periods, not premenopause or not perimenopause and not menopause, but those years before, those years where we're reproductive, right? And so you might have different symptoms that you don't realize that are associated with that. And you come to me maybe because you're not getting a period, or maybe you've got hair growth certain places. So these are all things that we're going to talk about today and kind of figure out how basically to define this, and then also kind of what it can cause in the human body.
Okay. So let's talk about the causes. What are the causes, risk factors?
What's really frustrating about PCOS is that there's really no exact cause, and it is kind of unknown. There's some studies that show that it is obviously multifactorial. Genetics can play a big part of it. I do see multiple families where I see all the sisters, or see the aunts and the cousins that all have PCOS. And if I treat one of them and then they're like, hey, you treated my cousin or you treated my sister. And, she actually was really, really happy with her results. And I was wondering if you could help me out too. So I do see a genetic line to this. I also see that there are environmental factors, right? So the American diet, I know we could really dig into this really deep, is, artificial sweeteners and also adding all of the additives that are added to the food. I do think that there is a possibility that these are adding to our increased risk as women to have hormonal issues, right? The high carb diet, obesity, right? The lack of movement of a lot of our females, right? So not exercising, having that central obesity, all of those things can lead to increasing your risk factors for polycystic ovarian syndrome. What's going on is it's a complete hormonal imbalance. And these ovaries, like we talked about in the last episode, are responsible for producing a lot of our female hormone. Estrogen, obviously, being one of them that like we talked about in the last episode, but also testosterone, right? Testosterone is a huge issue with our PCOS patients. These women create too much testosterone, okay? And when they are hyperandrogenic, which means they are creating too much testosterone, these are going to present in different symptoms. One big one that a lot of women complain of is hair where they don't want hair, right? So hair of their upper lip, hair of their chin, hair of their chest, hair on their nipples, hair on their back. These can be obviously embarrassing for them, can be so frustrating for them because no matter how much laser they do, remember that laser story that I told?
Okay. Wait, yours. Yes.
Yeah. I can't believe you got me to tell everybody that story.
Yeah, I have people come to me and say that was a really great story.
That's embarrassing. Jesus. Okay. But anyways, people spend lots of money on, getting this hair removed. And if it's a hyperandrogenism, where there's so much testosterone, no matter how much laser you do, a lot of times it doesn't work. And we actually have to find ways to lower that testosterone. And like we're going to talk about in a little bit, there are medications to help with that. The other thing is insulin resistance. And we're going to dive pretty deep into this, and I can get pretty nerdy with this, and Brittany's going to hold me back, I'm sure. But insulin resistance is one of those things where a lot of the American population has insulin resistance. And what does that mean? Our body normally makes insulin in response to what we eat. And so if we eat carbohydrates or we eat sugar or if we eat anything, it's going to release insulin from the pancreas. The job of insulin is to push that sugar or that carbohydrate into the cell. And what happens is our body overproduces this insulin. And when our body overproduces this insulin, the body says, hey, I don't need to use that. And it becomes resistant to the insulin that we make. Well, the problem with that is that not all of that sugar or that carbohydrates gets metabolized appropriately. And we start storing it. And when we store things like when we store carbohydrates or we store sugars or we store fats, guess what? We become overweight, and then that leads to obesity. So it's basically this horrible process where insulin resistance leads to obesity, obesity leads to insulin resistance, and then it just keeps going on and on. So we have got to find a way to stop that, right? We got to find a way to tell the body, hey, this is good stuff. You need to use my insulin because it is a good thing. And in a lot of these women, they're insulin resistant, which then leads to more symptoms of the PCOS. What happens is obesity causes obviously more fat cells. Estrogen is stored in fat cells. And then that anovulation starts to happen, right? Well, what does that mean? Like we mentioned earlier, the body is trying to ovulate, but it does not do it successfully. Ovulation is where we basically release the egg from the ovary in order for fertilization to occur. And normally this happens once a month on an ovulatory female. Okay. Somebody that is getting a period per the normal 28 days. And that ovulation is occurring, textbook says day 10 to 14, but just so you know, not everyone ovulates day 10 to 14. Just because your app tells you ovulate day 10 to 14, that's not necessarily true.
Apps don't lie.
Oh, okay. I'm going to tell you right now, that app does not know when you're ovulating unless you're doing ovulation predictor kits along with it, which is kind of cool. I don't know if a lot of y'all know about that, but there are these little, what we call OPKs, ovulation predictor kits, where you literally pee on a stick, just like you would a pregnancy test. And it tells you if you are releasing a hormone called luteinizing hormone, or LH. We normally, like I said, ovulate day 10 to 14, but most women, especially PCOS women, are not ovulating. And it's not going to happen day 10 to 14 if it does happen. And so these OPKs can be extremely helpful. And there are apps where it actually takes that OPK and actually uses that in the algorithm to tell you when your period is supposed to start, when you're supposed to ovulate, all of these things. So you can actually have a really good prediction of when is a good time to have sex in order to get pregnant.
Man, I wish I would have thought about that.
Right?
I'd be so rich.
Oh. Did you see that there's a new thing? Remember how you can obviously a pregnancy test, right? You pee on. Now they have one that checks FSH, follicle stimulating hormone. And so it will tell you if you're in menopause or not.
Stop.
I just don't know what you would do with that. I guess it picks up the FSH in the urine. And obviously if it's over a certain number, if the FSH is high, it'll tell you, yeah, you're menopausal. But if you're not having a period and you're around your late 40s, early 50s, I mean, just come see us. Let's talk about it. But I mean, maybe it's helpful, but I saw a commercial for it. I was like, that is crazy.
Interesting.
I mean, I love that women are wanting to know more about their body. And I love that companies are allowing women to know more about their body. But I just thought that was crazy.
Yeah.
I saw that on a commercial, I guess, last week. I thought that was interesting.
Yeah.
But anyways, let's get back on track. So symptoms of PCOS.
This is my job. Will you stop?
I'm so sorry.
Okay.
Well, you're not doing a very good job at keeping me on track because I'm talking about ovulation predictor kits.
I mean, I actually think that's very interesting. There's a lot of people that try to track their ovulation. So,
right. Well, and I think that a lot of women come to me and they have their app and they show me this app and they're like, well, it says I should have ovulated day 10 to 14. And then we actually draw post-ovulation labs and they did not ovulate day 10 to 14.
Jeanette, can we stay on track, please?
Okay.
All right. So let's talk a little bit about the symptoms that we typically see.
Yeah. So symptoms. God, these poor ladies, right? So first of all, their periods are going to be so crazy. A lot of times people will come to me and they'll say they haven't had a period in a year. Okay. So that's not a good thing, right? If you are not on birth control, and you have already had a period in your life, and then you go a good amount of time without a period, we need to see you, okay? Birth control can stop your period. And as long as you're on birth control and not having a period, that is okay. But if you are off birth control and you're not on any hormones and you are not having a period, I need to see you. Okay. So what happens is that lining of the uterus, okay, the part that we're supposed to bleed off every month with our period, it gets thick. Okay. It gets thick and thick and thick and thick. And what happens is that these ladies that are not having a period, they're building that super thick lining. And as long as that lining is staying there and basically not bleeding off every month, that then puts them at risk for having endometrial cancer, right? Which is obviously extremely scary. So the longer we leave an endometrial lining there, and that allows those cells to start changing, which then leads to increased risk of what we call hyperplasia. Hyperplasia is just the overgrowth of that tissue, which then can change those cells, which then obviously, like I just said, it can cause endometrial cancer. Mm-hmm. So if you're not having a period on your own, and you're not on birth control, you need to see somebody, right? Because this could be a sign that you have polycystic ovarian syndrome. These women will also go maybe like 2 periods in a month and then not bleed for 3 months. It's just kind of all over the place. And that's because of that anovulation, right? Or that lack of ovulation that's happening.
Yeah. This next one, we've already kind of touched on the hair growth.
Yeah.
But with the excess testosterone, we see hair growth, but we also see acne.
Yes.
And then we also see hair loss. And we're talking hair loss, typically top of the head hair loss.
Exactly. like hair thinning. They'll come to me and they're almost have like a male pattern hair loss. And that's obviously very embarrassing for a lot of women. Of course, they're growing hair where they don't want to grow hair. And then their hair on top of their head is so thin. They literally have balding spots. And they're embarrassed, right? And they just want answers and they just want a fix. And so that is a huge predictor that your testosterone is too high, right? So testosterone, though it, like we talked about in the last episode, it can be extremely helpful for our perimenopausal females. It can be extremely terrible for our PCOS ladies, right? So I never would want a PCOS lady to come to me and I prescribe testosterone, right? Because they already are making too much testosterone. So in those ladies, their symptoms are going to be acne, right? They're going to have that hair growth like you just talked about and that thinning of that hair. And those are all side effects from hyperandrogenism or hypertestosterone. Weight gain, we talked about this a little bit earlier, but that insulin resistance, right? That centralized obesity where these women are usually overweight. And don't get me wrong, there are a lot of ladies out there that actually have PCOS that are thin, right? Not every woman that has insulin resistance can be affected by the obesity part. So just because you are maybe normal weight or even underweight, that doesn't mean that you don't have PCOS, right? Yes, most of my ladies that I see that have PCOS deal with a weight, right? And they have that's very frustrating for them and they have a hard time losing the weight no matter how hard they work out in the gym or what they eat. But it can also happen with our thin ladies too, okay? This is another one that would only be found by ultrasound. And that what I mean by ultrasound is actually an ultrasound that's usually done what we call transvaginally. That means where we actually use this probe and it actually goes inside the vagina and we do an ultrasound of the ovaries and the uterus. And what that looks at is it looks for those little cysts, like we talked about, those little fluid-filled sacs along the outside of the ovary. And what it has on it is what we call the string of pearls pattern, okay? It literally looks like somebody laid a string of pearls over the side of your ovary. And these are all those little fluid-filled sacs that have just basically where the ovary has tried to ovulate and it was not successful.
Right.
And these are really obviously the only way we would be able to see that is through imaging.
And we're also seeing some mental health issues frequently.
Yeah. And that goes back to, I think, the body image, right? These ladies are losing their hair. They have acne. They're overweight. They have hair where they don't want to have hair. Maybe they are trying to get pregnant and they can't get pregnant. They've got a lot of fear, right? There's a lot of fear around that. I know there's a lot of fear around infertility, right? Just infertility, not even PCOS, but fear of infertility in a female. So I think these things create a mental health issue, right? That goes untalked about, right? And I think that's why you and I started this, right? Is to make it more available that you're not the only one going through it and there are ways to help you through it.
Right. And just you touched on infertility, but this is the most common cause of infertility.
Isn't that nuts? I didn't realize that it was the most common cause, but like you said, 1 in 10 women. So 10% of the population is dealing with that, right? So then you look at infertility and how many women come to me who maybe are not ovulating or not having these normal periods. And it would make sense that it's the PCOS that is causing that.
So how is this diagnosed? I know we touched on the ultrasound, but there are, I know, other...
Yeah. So there's actually a criteria that we go by, and this is called the Rotterdam criteria. And in order to diagnose somebody with PCOS, you have to have 2 of 3 things. Okay. These 3 things are going to be irregular ovulation, right? So like we talked about, the periods are going to be abnormal. Androgen excess, so high testosterone, which then leads to the symptoms like we've already mentioned. And then polycystic ovaries found on ultrasound, right? So as long as a woman has 2 of these 3 things, I can diagnose them with PCOS. A lot of times women have all 3, right? And with all 3 of these things, obviously there are a lot of things that we have to actually treat multifactorial, right?
Right. And I know there are some, I wouldn't say rare, but certain cases where it doesn't present with the pearls that you spoke of, where they could have PCOS, but you don't necessarily present that on ultrasound.
You're right. You're right. And they could have just 2 of those 3 and the ultrasound does not show PCOS. Just because your ultrasound doesn't have PCOS on it doesn't mean you don't have PCOS because as with the body, this is ever changing, fluctuating, right? Just because we ultrasound on a Tuesday on January 5th and it doesn't show that you have string of pearls doesn't mean that in March 3rd, you're going to have that string of pearls pattern. So whatever your body is doing at that time of ultrasound is basically going to be helpful, but not diagnostic, right?
Really?
So the other thing that a lot of women come to me and ask, is there a blood test, right? Is there a blood test that I could do on you that's going to tell me if you have PCOS? If I work you up for PCOS, I do blood work, right? I do some common tests. One of those, or a couple of those are going to be the follicle stimulating hormone, the FSH, like we talked about in the last episode. That tells me if you're not having a period, are you like maybe pre-menopause or perimenopause, or maybe even your early menopause, right? So I need to rule that out. I'm going to check your estrogen levels. I'm going to check that luteinizing hormone, that one we talked about that we pick up on those ovulation predictor kits to see if your body is sending down that hormone to tell your body to ovulate. I'm going to check a testosterone level, right? These women that have PCOS have high levels of testosterone. Their levels are higher than your normal range, right? I'm also going to check a fasting insulin. This is important that the fasting or the insulin is done fasting. Okay. Remember we talked about earlier, if you eat something, your insulin's automatically going to go up. So I need to know what your insulin is without eating. Okay. So that insulin needs to be drawn in the morning. Okay. And then the other thing is the A1C. Okay. The hemoglobin A1C is an average blood sugar over 3 months. It gives us a number anywhere from about 4.5%, the highest I've ever seen. I think I saw 18 once.
In my other job, and again, I work in internal medicine.
Right.
So I'm working with a lot of chronic issues. And I can't tell you how many times I see A1Cs above 13.
Woof.
Which these are patients that need better management.
Well, sure. Absolutely.
But I will tell you, even as a provider who has seen this multiple times, when I see it, it's still like a little shocking.
Absolutely.
And it also has made me believe that I may have diabetes myself.
Okay, you do not have diabetes.
I know, but I'm explaining to you that I checked my A1C because I was convinced. I don't remember. I was like, I think it was like 5.2.
Okay, so that's non-diabetic.
I know.
That's not even pre-diabetes.
But I had convinced myself after seeing multiple A1Cs above that I had it.
Oh, when I was in PA school, I thought I had colon cancer. I thought I had stomach cancer. I thought
it's very easy to convince yourself of everything.
Everything I learned, I had it.
Mm-hmm.
Oh my God, this is ridiculous. I'm glad to hear that you thought the same thing, because I was starting to think that I was a hypochondriac. Maybe I am though. But as far as the A1C, going back to that, a lot of these ladies have pre-diabetes, and that's from that long-term insulin resistance.
Right, and they don't know it.
They have no idea. Clue.
Yeah.
And, diabetes, you're going to want to have an A1C. Oh, this changes all the time. And I kind of go back and forth on this. An A1C over 7 is what they say is diabetic. But honestly, I don't want you to be over 6.5. Because that tells me that there's something going on at the cellular level that needs to be changed, or 3, 4, 5 years from now, we're going to be dealing with a significant diabetes, right? So these PCOS ladies are at higher risk of becoming diabetic. So I do check an A1C on them just to make sure that we're not in that area already. And then obviously we talked about the ultrasound, right? That's another part of my workup. So you're going to come to me, you're going to have the blood work done. I'm going to get the ultrasound. And then I'm going to probably have you come back and we'll talk about all of that in detail. And we'll kind of figure it out as far as a plan going forward for you.
Yeah. And there are a few conditions that kind of present the same way, or can. And I know that talking about some thyroid disorders,
right,
adrenal gland problems, there's obviously a multitude, but those are ones that can really disguise themselves.
Yeah, there's a big thing on social media right now. I guess I said I was good at TikTok, but I'm not.
Still working on it.
Yeah,
again, I took over, so please stop.
And you haven't even made one since you said that you were going to.
That's not true.
We made one. It was together.
Okay, but you have not given me time. My brain is slow.
Okay.
I was on vocal rest.
Oh, yes. I'm sorry. I forgot.
Thank you.
Were on vocal rest.
Jesus.
Jeez. Okay. I'm sorry. Jeez.
Okay, keep going. You saw tips.
No. So there's a big thing right now is hypercortisol.
Cortisol. Oh my God, I know.
Everybody wants to get their cortisol checked. But I think what people don't realize is how hard it is to check a cortisol level. Like we're talking, I need your cortisol first thing you step out of that bed. I need you to see what your cortisol level is. And we have to actually track it, right? So just going and getting in a random cortisol level, it's not going to tell you much. So
TikTok says you can do it.
That's not true. That's not true. And if somebody can help me out and says that it is true and you can show me the science, I want to see it. But these ladies, they want to see what their cortisol level is. And cortisol goes up with lots of things. Cortisol goes up with stress. Cortisol goes up with lack of sleep. Cortisol goes up with infection. So I tend to try to tell my ladies, hey, let's not worry about cortisol levels right now. Let's check all these other hormones that are easily accessible during a normal blood draw, right?
Yeah. We need to move on to treatments. Let's do it.
Okay.
Let's do it.
Okay.
Let's do it.
Got it. So management and treatment options. So the big thing right here is lifestyle changes, right? I want you to really work on the diet part. I want you to be eating low carb. I want you to be exercising. I want you to make sure that what you're putting in your body is good and healthy food, right? Don't get me wrong. I love myself a good plate of nachos. You know what? I like ballpark nachos.
Oh.
So the boys playing baseball is not a good thing for my waistline because guess what we eat all weekend? Nachos. And they're so good. What is it with that Rico's cheese? Do you like that?
Yeah. I mean, I couldn't tell you the last time I had ballpark
that is
nachos.
Really sad.
Well, I know, but when I go to a baseball game, when I used to go to the Astros game,
yes,
I think it was on Wednesdays. This was before the Astros were like winning the World Series again. They had $1 hot dog night. I have never seen so many people eat. I'm not even kidding. There would be people in front of me and they'd be getting 20 hot dogs.
No.
I mean, it was for their whole family, but like $20 in an Astros game.
That's great. Because you know what $20 will get you now at an Astros game? Not even a thing of nachos.
Water, maybe. I don't know. But nachos, yes.
Yes.
I know.
And it's not even real cheese. It's not real. It comes out of a can. And this is the kind of stuff I'm telling you not to eat, but damn, it's good, right? Okay. So anyways, just basically getting good nutrients in your body, right? Getting all the vegetables that you're supposed to have, getting all of the exercise you're supposed to have, getting good quality sleep. These are all going to help your body run at its best level. Okay. And then there's medications, right? This is the part that obviously some people don't want to do, right? Some people want to try to go as natural as possible, which there are some really, really great options that are on the market. Berberine is a really good natural option. I have a lot of patients that take berberine that I recommend. So that is an option to help with PCOS. But medications that I prescribe, number one, birth control. Okay. Because like we talked about in the very beginning, these ladies do not ovulate. Therefore, they're not having good regular periods. And I have got to know that we're protecting that endometrial lining. So there's different options to do as far as birth control. There are your typical birth control pill, right? That's a combination pill that contains estrogen and progesterone, or even a progesterone only pill that's just progesterone. What that's going to do is keep that lining thin. It's going to prevent the ovulation from occurring. And a lot of times does help the cyst formation. Okay. And then there are IUDs, right? Where intrauterine devices, where we place this IUD inside the uterus, and that keeps that lining thin. The only ones that are going to keep that lining thin are going to be the ones that contain the progesterone, like we talked about last time. The Mirena, the Skyla, the Liletta. Remember those really sexy names?
Yes, and that child that was named.
Oh, poor Kylena. Yes. Oh, yes. And then, then there's obviously other things as far as birth control. There's the Depot shot, which is a shot that women can get every 3 months that keeps that lining thin. It's progesterone only. And then there's the Nexplanon, which is a little plastic device that goes underneath the skin right in the arm. And that stays for 3 years, which then also helps with the thinning of that lining. And then there's medications to help with all of those hyperandrogenism, right? That's where we talked about last time, where the testosterone's really high and causing the acne and causing the hair thinning and causing the hair growth. And there's a medication that we commonly use, and I know you commonly prescribe it as well, and it's called spironolactone, okay? Spironolactone is actually a diuretic, but it actually blocks that androgen from causing all of these side effects in women. It comes in multiple different doses, but it is a pill that you would take once a day that is only a prescription that you would get from your provider. And it does help with that hair growth that you're getting from that hypertestosterone.
Yeah, and I think when people hear diuretic, to be used to help with hair growth, acne. It's a little confusing.
Very much so.
But I will tell you, this is used in dermatology widely.
Absolutely.
So if you do get the option of spironolactone and you're having these issues and you can't find a solution, it is definitely something worth trying.
Yeah, I've had a lot of success with using that, even at a low dose. Even at 25 milligrams, it can do a lot of good things for these ladies. There are some women that need the 100 milligrams in order to control their symptoms, but it's obviously patient dependent.
Yeah.
Here's the big one. The mainstay of treatment for insulin resistance with PCOS patients, and the one that is tried and true, is metformin. Okay. Metformin is a pill. It's commonly used in diabetes, but what it does is it helps the body recognize its own insulin, right? And see it as a good thing. There are a slew of side effects that come along with metformin, mostly gastroenterology stuff, right? So GI, right? So you're going to have stomach upset, diarrhea, sometimes some nausea, some vomiting that's associated with this medication. But it works. It works really well. I do recommend that if you're going to be put on metformin, I do recommend the extended release form of metformin. And the reason for that is because it has a little bit less side effect GI wise. So a lot of times insurance will kind of push back on that. But if you try the regular release metformin first, and then you basically document that the patient had side effects, a lot of times you can get that extended release. So if you're on metformin and that metformin is really hard on your stomach and you're having lots of diarrhea, ask your provider to try the extended release. And a lot of times it will fix that for you. But the big one out, right? I'm sure everybody knows about this one. This is the GLP-1 class, right? These are going to be your Ozempics. These are going to be your Wegovy's. These are going to be Mounjaros, the Zepbound, all the ones that are everybody's talking about. These are the weight loss miracles, right? I think this could actually have its own episode, right? Me just talking about GLP-1s.
No, I think we need it.
I do too.
We get asked about this
all day. Yes. Yeah. And it is commonly used for weight loss. But I think the mainstay of treatment that I think a lot of us forget about is this is originally a diabetes drug. Yes, it's used for diabetes, or yes, it's used for weight loss. I prescribe it all day for weight loss, but I also prescribe it for my PCOS ladies because maybe they've tried metformin and they couldn't handle the side effects, or maybe it didn't work for them. Maybe it just didn't help them with all of their symptoms. These medications have been a true life changer for them. And so there are a lot of really great options, and this is a provider-patient conversation that you have to have. But, the ones that are on the market, sometimes you have to have a diabetes diagnosis depending on the insurance in order to get them covered. But there are obviously ways to get around that and go through more of like a compounding pharmacy that is trusted by your provider. And so I think we're going to have to do a whole episode on GLP-1s. I really do. But if you have questions, obviously send a message on the side. But these are something that I have seen personally in my patients that have helped tremendously with the weight loss. And then once the weight loss starts to happen, guess what these ladies are starting to do? They're starting to ovulate, right? They're starting to get that insulin resistance down, that testosterone's coming down with the spironolactone. And guess what? We are ovulating. And I have had some ladies that have actually gotten pregnant. And it's actually really exciting to see the future of this for my PCOS ladies.
Okay. What about infertility treatment? I mean, again, this is such a huge thing that we will also have to hopefully bring someone in to talk about, because it's just very dense. It's
so true.
Yeah.
And there's so many reasons, right? There's so many reasons for infertility. PCOS, like you mentioned, is obviously a big one. So going back to the anovulation, there are medications that, though if we've ruled everything else out as far as this is truly the fact that you're not getting pregnant is because you're not ovulating is due to your PCOS. Once we get that spironolactone, or once we get that testosterone down and your insulin is now working appropriately, there are medications that we can use like letrozole or Clomid to actually induce the ovulation to occur. Okay. This is a process, right? This is providing progesterone, right? This is providing, which is obviously another hormone, giving these medications at a certain time in order to cause that ovulation, and then having timed intercourse in order to try to get pregnant. And then the last resort, say none of this works, right? Then we're stuck with IUI, right? Or in vitro fertilization, right? So there's a couple of different options that honestly, that you would be referred to a fertility specialist in order to try to get that taken care of.
Absolutely. Right? And then lastly, just the mental health part of this.
Mm-hmm.
Obviously, there's, we have said this many times, therapy always.
Absolutely.
And then also support groups. Get on your, what do they call it? Forum?
Oh, the forum, like a chat group. What are they called? Chat rooms? Remember those?
Okay. Jeanette, we're trying not to act like we...
Did you ever get on those? The chat rooms?
I mean, duh. What was your AOL name?
I'm not saying that out loud.
What? You can't say it out loud?
No. You ready?
I'm so nervous.
No. Okay. Panther Baller. What? So my high school mascot was a panther.
So was mine.
And I was a basketball player.
So was I.
I was a Panther Baller.
I cannot.
Why do you always make me tell the whole world these things?
Well, I want to make a point that I was also a Panther, and I also played sports.
I would have beat you. Okay.
Okay. Wow. I'm not even going to follow. I have nothing good to follow with that.
Great.
Yeah.
Okay. So going back to it is getting on these support groups and getting some people that are also going through these things that you are, right? And finding that sometimes finding others that are also going through something with you at the same time can be extremely helpful because y'all can find answers together.
Got it. Okay. Panther Baller, can you answer a few of these frequently asked questions?
I'm ready.
Ready?
Hit me.
Can you cure PCOS?
Ooh. I don't know if you can cure it, but you can absolutely fix all the problems that comes from it, right? So lowering that insulin resistance, helping that weight loss, getting you to ovulate, getting your periods on track. So I think that not necessarily curing it, but absolutely helping you through it with helping the different things that come from it.
Okay. And can you get pregnant with PCOS?
100%. I have ladies all the time. And don't let somebody tell you that you have PCOS and you can't get pregnant. Yes, there are ways to do this, okay? But it all comes back down to getting it under control, right? And yes, there are some ladies out there that have PCOS that maybe really deal with infertility and they've gone through infertility treatment and still were not able to conceive. And I'm brokenhearted for those women. But don't let just somebody telling you it's not possible without going through all the treatments be your one answer.
All right.
Okay.
And here's another, this is the last one.
Okay.
Is PCOS the same as ovarian cysts?
So PCOS has multiple cysts, but a lot of women can have one cyst, right? There are a lot of women that come to me that maybe have an ovarian cyst on one of their ovaries that's found by ultrasound, or maybe they've had pain and we do an ultrasound for it. But that one cyst doesn't mean you have PCOS. Okay. Remember we talked about earlier, it's a syndrome. It's a multifactorial thing. So just because you have one cyst, that does not mean that you have PCOS because you have to meet that Rotterdam criteria.
Okay. Nice. Wow.
Like that?
Yeah.
Woo.
So we have a new segment. And we've asked people to write in with any questions. And we've gotten some good ones.
We got some really good ones.
Okay, so we're going to introduce this. So wait for it, guys. This segment is called Slippery Solutions with B&J.
Okay.
You like it?
I do.
Okay.
Yeah, it's really good.
Question 1.
Okay. Ready for it. Hit me.
Will a vibrator make my clit more desensitized to stimulation from my partner?
Yes, absolutely. So remember, that's a huge nerve bundle. Okay. It's full of nerves. And if those nerve bundles are used to only a vibratory effect from an actual toy, sometimes the body can only get an orgasm by having that same vibratory sense. So I would absolutely recommend that you interchange the two. So either you use a vibrator sometimes, and then obviously oral stimulation or manual stimulation, but you have to change it up because your body will get desensitized to something that is not as vibratory as obviously the vibrator itself.
Skilled.
Okay. Yeah, that's a great word. Skilled.
Oh, thank you.
Yeah.
Thank you, Jay.
Oh, sure, B.
Okay, here's another one. I recently had a baby and couldn't be happier with her and the joy she has brought to my life. But I find myself feeling guilty because I wonder, will things ever go back to normal with my body in my relationship? Everything feels so different in a great way, but also in an unfamiliar way.
Oh, this is a really good teaser actually into our next episode, which is postpartum. Man, our body takes such a hit after we have a baby, and nobody talks about this one. Are you ever going to feel back to normal? Yes. Okay. There's light at the end of that postpartum tunnel. It's going to be a different normal than you had before a baby. Just going to be flat out honest with you. But we can still find joy in the things of our body, still find joy in sex, still find joy in our partner, still find joy in our relationships, still find joy in our postpartum body and what that looks like. There are some women that are truly blessed that bounce back to sometimes better than they were prior to having a baby. But for the most, that's not the case, right? So I would love to, in the next postpartum episode that we're going to talk about all these things, kind of help you find that joy again, right? And help you kind of tease through all of that to figure out how to truly look at yourself in a different light and more as a mother now, and kind of what that feels like with that new title. But yeah, it will get better. It will. And especially if you're in that first 3 to 4 months where your hair's starting to fall out and your nipples are raw and your boobs don't look anywhere near what they used to. And if you're still breastfeeding, your vagina's dry and sex hurts and maybe you have no libido, right? But yeah, this too shall pass. But I can help you through that part too.
We love that.
Oh, good. Good.
Guys, don't be scared to send in any questions.
Oh, yeah.
Clearly,
I actually love the questions. I get so excited when we get an email or a message. I get so excited. That's my nerd coming out. But we want to help you.
Yes. That's it.
That's it.
That's all we got.
I hope you learned something. Looking forward to chatting with you again at the next episode. Please follow us on Instagram. Follow us on our TikTok. And then obviously there's always our website where we've got links to products that we talk about during the episodes. You can obviously find all of our episodes on there. There's some bios about myself and Brittany. And we look forward to chatting with you again next time. Bye.
Bye.
The information provided in this podcast is for general informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition. There is no provider-patient relationship formed. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. The hosts, guests, and producers of the podcast do not assume any liability for the application of the information discussed. Reliance on any information provided by this podcast is solely at your own risk.